everyone, this is the Plastic Guru, and today we will be talking briefly about carpal tunnel syndrome. So first of all, what is the nerve that is involved? It is the median nerve, and the root of it is from the brachial plexus and specifically from C5 to C7. And what is the motor supply of the median nerve? We have so many muscles. First of all, we have the pronators, which is the pronator teres and the pronator quadratus. And we also have the flexors, which are the flexor radialis, the flexor ulnaris, as you can see here, flexor carpi ulnaris and flexor radialis, as well as flexor carpi radialis, and also the flexor digitorum profundus and the superficialis and the pollicis. So we have here the flexor digitorum profundus and the superficialis. You can imagine it here reaching this area, and the pollicis. The flexor pollicis longus, this muscle in red. Also, we have the palmaris longus, which is this one that is not under the carpal ligament. Also, we have the intrinsic hand muscles, which are basically the flexor pollicis brevis, the abductor pollicis brevis, and the opponens pollicis muscle. So we have here the flexor pollicis brevis, and which is the superficial belly, the abductor, and the opponens. So the opponens is most lateral, the flexor is most medial. Anyways, also we have the hand muscles, which are basically the index and the lumbricals of the index and the middle finger. So as you can see here, this finger and the middle finger lumbricals, which are here, and these lumbricals are supplied by the ulnar nerve. Moving on to the sensory involvement. So what is involved in the sensory? We have the infamous picture of the hand that you probably studied in your earlier years in medical school, which is basically the involvement of the thumb, the palmar aspect as well, the index finger, the middle finger, and half of the ring finger, and which is the radial half of the ring finger, in addition to the distal interphalangeal phalanx of each of the digits involved. So, what is the carpal tunnel? Moving further into the anatomy. So basically, the carpal tunnel is a tunnel. So what is involved? We have the floor, which is basically the bones. We have the radial aspect, which is basically also the carpal bones, and the ulnar aspects, which also involves the carpal bones, and we will see them right now. So basically, this is the ulna, this is the radius. So in the radial side, we have the scaphoid, we have the trapezium, as you can see here. So this is the scaphoid creating the ulnar wall and the trapezium. And in the ulnar side, we have the triquetrum, the pisiform, and the hamate, creating the ulnar floor, the ulnar side. Also, we have the roof, and which is the problem in this disease, which is the transverse carpal ligament. So it's the transverse ligament covering the content of it. Moving on to the content of the carpal tunnel, we basically have 9 tendons. 4 of them are tendons of the flexor digitorum profundus, and 4 of them are tendons of the flexor digitorum superficialis, and don't forget the thumb, which is the flexor pollicis longus. So basically approximately all the flexors of all the digits. So 4 plus 1. These are the tendons, in addition to the cause of all pain, the medial nerve. So moving on to the approach, we have the history. Generally, the patient will present with weakness, numbness, and paresthesia. And usually, pathophysiologically, the patient will start by weakness, then numbness, then muscle atrophy. And regarding the history of presenting illness, you have to know the duration, if it's related to activity or not. Does it wake up the patient from sleep? Is it related to the workplace or the environment that the patient is in, or the type of work the patient is involved in? So this is an important question, and the most important question here is does it correlate with neck pain? If it correlates with neck pain, this is a differential diagnosis. And does the patient drop items or not? Further, you have the risk factors that are important to ask about, which are if the patient has any autoimmune diseases like the thyroid, especially the hypothyroidism, diabetes, collagen vascular diseases, amyloidosis, pregnancy and obesity, which all create pressure by one way or another. Okay. Moving on to the physical exam. Physical exam is quite simple. You have the sensory, you have the motor exam of the hand, and the most important tests are the Fallon test, which is to ask the patient to do this maneuver for about a minute, and if it elicits pain in the motor supply that we just explained, then this is a positive test. Further, you have the Tinel sign, which is basically eliciting percussion or very light percussion on the site of the carpal tunnel, basically where the median nerve passes, and does it cause tingling to the site of motor involvement. Regarding imaging, not usually done, but when necessary or when a differential is in mind, x-rays could be useful, ultrasounds could be useful, and MRI if you are thinking about a soft tissue differential like a tumor that is compressing the median nerve or something of that source. But the ultimate confirmatory test is the nerve conduction study. Last but not least, we have the treatment. So regarding the approach to treatment, we have the non-surgical approach and we have the surgical approach. The non-surgical approach basically is compromised by wrist, cock-up splint, activity modification, and basically to relieve the pressure on the wrist, and also the patient might benefit from a steroid injection or using NSAIDs, or the patient could use the surgical approach, which has less recurrence rate, better patient satisfaction, but all surgeries are involved with post-operative complications that the patient must know of. And the surgery is basically having a median incision and opening the transverse carpal ligament and relieving the pressure and closing the skin with a suture. So it's a pretty simple procedure with great benefit. And thank you for watching.